Greetings from San Francisco. My name is Ricardo Muñoz. I'm professor of clinical psychology at Palo Alto University. My talk today is titled Leading the Charge Toward a World Without Depression, a worthy challenge for the next 40 years of the Marcé Society. I'd like to begin by congratulating members of the Society on their 40th anniversary. I'm very happy to be able to contribute to the 2020 conference. My thoughts behind this presentation are that essential tasks to benefit humanity often require several lifetimes. Marcé's work on perinatal mental illness was published in 1858. The Marcé Society was established in 1980. Depression treatment randomized controlled trials began to appear in the 1960s, and depression prevention randomized controlled trials in the 1980s. And just last year, the U.S. Preventive Services Task Force recommended preventing perinatal depression. We don't know when routine application of preventive interventions for perinatal depression will be established throughout the world, but that is a worthy challenge for the Marcé Society's next 40 years. The main points I'd like to make are that perinatal depression can now be prevented. I'd like to share a 50-year personal perspective on prevention research and argue that we can now prevent 50% of onsets of perinatal depression. And the question now is how to implement what we know across the world. And of course, we need to look at promising paths to pursue to prevent the additional 50%. Last year, I published an article in the journal Nature in which I argued that the first priority for preventing depression should be preventing depression during pregnancy, because not only does that benefit the mother, but it benefits the baby as well, and it could have lifelong impact on their health and mental health. The article that I published was partly triggered by this article that appeared in February in JAMA. The U.S. Preventive Services Task Force issued a recommendation that clinicians provide or refer pregnant and postpartum women who are at increased risk for perinatal depression to counseling interventions. And in that same issue, O'Connor and colleagues presented results from a systematic review that found that the pooled risk ratio for all 17 trials that they were able to identify was 0.61, which transfers to a 39% reduction in incidence across all the trials. But they also pointed out that there were two sets of prevention programs, one based on CBT, the Mothers and Babies program, and one based on interpersonal psychotherapy ideas called the ROSE program, that yielded reductions in incidence of 53 and 50%. So this is the evidence for why I argue that we now have the knowledge to prevent half of all onsets of perinatal depression. Now I'd like to share with you quickly, of course, 50 years of work on the road to prevention. 50 years ago, in 1970, I began work on psychology, declaring my major at Stanford University. In '71, I did a senior honor thesis consisting of a randomized controlled trial supervised by Albert Bandura, from whom I have many of my ideas, including self-efficacy, for example. In 1972, I went to the University of Oregon to begin my doctorate work, and that's when I heard about prevention. I attended a meeting of the Community Mental Health Center in Eugene, Oregon, at which a psychologist gave an impassioned talk of something he called primary prevention. In brief, he chided the mental health professionals around the room by saying, you know, we sit in our offices and we wait for people to suffer enough to have to come to see us. As mental health professionals, we should be going out into the community and teaching people what we know so that they can prevent the problems that eventually bring them to our offices. I found that message so compelling that I have dedicated a large portion of my professional career to prevention in addition to treatment. So in 1975, I published my first publication titled Prevention of Mental Disorders. In 1975 to 77, I did my dissertation under the direction of Peter Lewinson as part of a large-scale depression treatment randomized controlled trial using cognitive behavioral ideas. From 1977 on, I've been a professor at the University of California, San Francisco, based at San Francisco General Hospital. And in 2012, I joined Palo Alto University, where I am the founding director of the Institute for International Internet Interventions for Health, or I4Health, as we call it. Now, in 75, this is my first publication done with my mentor, Jim Kelly, who sadly passed away this year. In this chapter, we put together what evidence there was for the potential for prevention. And when I did my dissertation with Peter Lewinson, who was one of the pioneers in the area of behavioral activation, and the dissertation was done in collaboration with two other graduate students at the time, Marianne Youngren and Tony Zeiss. We looked at the effectiveness of behavioral, cognitive, or interpersonal interventions. And the interventions that we used in the dissertation are now in this book called Control Your Depression. These are the methods that I've been using from then on in my work on preventing depression. Now, in 1984, the state of the science was such that the National Institute of Mental Health could publish this document stating that the onset of a clinical depression cannot be prevented. We've come a long way since then, so let me share some of those things with you. Because of the fact that that was the state of the science then, I redoubled my efforts to try to understand how we could do the research necessary to show that depression could be prevented. This book in 1993 went into great detail on what we needed to do to prevent depression and documented the first randomized controlled trial done to prevent the onset of depression, which my team conducted at San Francisco General Hospital. In 1997, Mimi Lay came to do her internship and postdoctoral training at San Francisco General Hospital. And she and I developed the Mothers and Babies course, and we ran a small pilot study with women, Spanish and English-speaking women who were at high risk for depression, and showed that the incidence in the control group, the proportion of new onsets of perinatal depression in a year was 25%. But in our intervention group that received the Mothers and Babies course, we were able to reduce the incidence to 14%. These are some of the women and their babies who took part in the Mothers and Babies course. The babies, of course, were in the mother's womb when they were taking the course. And of course, this is the reason that we do this work, right? It's to benefit the mothers and babies like these. Now, the manual that we developed is available. It can be downloaded for free from our website, i4health.paloaltou.edu. And it's based on this idea of the healthy management of reality, which was inspired by Bandura's work on self-efficacy, how we can basically manage our own reality. You can download this also from i4health.paloaltou.edu at no charge. And what we teach women in the Mothers and Babies course is that our personal reality is made up of two parts. Our internal reality is what's in our mind, our thoughts, our memories, our expectations, and so on. And our external reality is the physical world. And we share with them the cognitive behavioral model that basically shows that our emotions can affect what we do and what we think. But luckily, because the opposite is also true, we can use our thoughts to manage our mood, and we can use our activities in the same way. And of course, our thoughts and activities also influence each other. We make clear to let the mothers know that we're not trying to prevent all emotions or all feelings, right? Depression and anxiety are actually healthy responses to life, just like pain is. And just like pain, we would not want to get rid of all pain. We want to get rid of chronic pain, right? The kind of pain that disables people. Depression and anxiety are signs that our lives are having too much stress or that there is danger in our environment. And it helps us to respond to those stressful events or to those dangerous situations. We don't want to get rid of normal depression and normal anxiety. What we're trying to prevent is clinical depression, the kind of depression that produces disability, that interferes with our life or activities a lot. We present this figure in which each of the vertical columns is a moment in time. And we tell our participants in the mothers and babies course that imagine that this circle, the leftmost circle here, is the current moment, right? So at any moment, we have three choices. We can think or do something that will improve our mood, leave it as is, or worsen it. And once we've made that choice, in the next moment, we have three choices. We can improve our mood, leave it as is, or worsen it depending on what we choose to think or do. And so throughout the day, we're making these choices, which can either lead to a positive mood state or to a negative mood state. And by making these choices throughout our day-to-day life, we increase or decrease the risk of eventually becoming clinically depressed. Last year, the National Academies of Science, Engineering, and Medicine published this consensus study report. I was a member of the committee that published this. It was titled Fostering Healthy Mental, Emotional, and Behavioral Development in Children and Youth. And there were two main messages here. One is that we now have the knowledge to prevent many mental disorders, and we need now to implement them. And that we need to go beyond individually focused interventions and focus on family, community, and societal influences if we really want to reduce the incidence and prevalence of these mental disorders in the general population. The committee put together this figure which shows the mental health intervention spectrum. Treatment and maintenance interventions are on the right, and we focused a lot on prevention of mental disorders as well as promotion of healthy development. And the committee put a strong emphasis on the fact that we need to go beyond individual interventions and focus on the family, the community, and societal factors that have an influence on healthy development and, again, the incidence of mental disorders. So some of the implications of this report for the Marcé Society is that we need to be focusing on both implementation and sustainability. We need to train more providers. We need to reduce drift from the interventions as they're tested. And we need to reach people in remote locations. We also need to scale up. We need to reach the highest absolute number of people because dropout rates are very high. And we need to reduce dependence on limited provider time because limited provider time is consumable and it limits how many people we can reach. And of course, we always need to focus on cost. So to give you some ideas as to how we may be able to scale up, I want to share with you some of my work in another line of research. So these are lessons from work on an online smoking cessation set of studies. In 1997, I wrote my first grant to test the effectiveness of internet interventions. The focus was to help people stop smoking, and we did this in Spanish and English. First, we looked at the smoking cessation rates for the methods used to help people quit smoking. For example, the nicotine patch is clearly more effective than placebo patches. Placebo patches yield 4 to 8% quit rates at 6 months. The nicotine patch, 14 to 22% quit rates. Smoking cessation groups yield 24 to 27%, which means that we can help about a quarter of people who are having a hard time quitting to quit using these interventions. So my question was, could a web-based smoking cessation intervention match the patch, match the effectiveness of the patch? So we put together a website to get proof of concept as to whether this could be done. And in fact, we were able to match the patch. Our best condition tested yielded 26% quit rates at 6 months and 20 and 21% quit rates at 12 months. So we were able to match the patch. But what I found most interesting was the reach. Every red dot here represents a zip code that has at least one visitor to our website. So from San Francisco General Hospital, a small group of mental health providers were able to reach people throughout the United States. And more interestingly, we were able to reach people throughout the world. The darker the country, the more people who kept on coming to our website year to year. Now, I find this remarkable, right? I mean, there's a way in which now we can do things that we could not do back when I got my Ph.D. in 1977. And I think we need to take advantage of that if we really want to reach as many people as possible throughout the world. So we came up with this idea that, like massive open online courses or MOOCs, we should be developing massive open online interventions or MOOCs to deliver behavioral health services worldwide. Now, there are several issues with doing this. One of them is that massive open online interventions do have massive reach, but they also have massive attrition. So we need to look at absolute numbers as well as percentage completion. Here's an example of a MOOC from MIT, the Massachusetts Institute of Technology, a course on circuits and electronics, registered 155,000 people throughout the world, but only 7,000 plus passed the course, which is 4.6%. This would be very disappointing, of course, but one of the people involved with the course pointed out that if you look at the number in absolute terms, it's as many students as might take the course in 40 years at MIT, right? I mean, how many people can we reach face-to-face compared to how many people we can reach using online interventions or digital tools like apps? Another major issue, of course, is cost. Right? In our last study, we had 3,479 smokers using our website across the world who gave us data indicating they had quit. This is out of 18,000 plus people who had entered our study. So it was a 19% quit rate. Now, to help that many smokers quit, it would have taken over $3.5 million worth of nicotine patches. We were able to do this in 2.5 years for about $200,000 by keeping the research website open after the grant that had funded our randomized controlled trial ended. Right? Now, you may ask, how did you get $3.5 million? Let's do the numbers. Nicotine patches cost $3 to $4 each. So assuming a $3 per patch cost, in 7 days or in a week, we have $21. In 10 weeks, $210. Patches yield quit rates of 14 to 22%. So to make it easy, let's use 20% as our estimate, which means that 1 out of 5 people who use the patch are able to quit. So to get 3,479 smokers to quit, we would have to give the patches to 5 times that many, or a total of 17,395 smokers. You multiply that times 210 per smoker, and you get 3,652,950. Consumable interventions are very expensive. So we've come up now with this idea of digital apothecaries, which would be online repositories for MOOCs that would make healthcare interventions available and accessible worldwide. Okay? Now, I keep on saying that we can prevent 50% of cases with individually focused ecological interventions, right? The question is, does this work routinely? The studies I've mentioned come from randomized controlled trials, which are very tightly controlled, high quality administration of the interventions. What happens when you use this routinely? Well, I found this report published in 2015 from the UK, in which they looked at the use of psychological therapies in National Health Service. Over 1.25 million people were referred for treatment during this year, and about 400,000 completed treatment. And here are the recovery rates, right? They hover around 50%. Cognitive behavioral therapy down at the bottom at that 44% recovery rate, and computerized CBT at 58%. So somewhere between 44 and 58% of people recover. And note that computerized CBT, which is self-administered, fully automated interventions, does very well in the real world. So we would not be offering people an inferior kind of intervention if we focused on doing this through the web. Now I want to talk about how digital apothecaries could contribute to administer 4 types of interventions. Type 1 are face-to-face preventive interventions, the kind that we've all been trained to do, where we can do interventions individually or in a group format. Type 2 are those interventions enhanced with digital adjuncts, such as apps or websites, for example. Type 3 and 4 are self-help interventions done online with no therapist involved. But type 3 does have a helper who helps, or a coach, if you will, who helps the person to adhere to the intervention and not to drop out. And then type 4 are fully automated. There's no human contact involved. That makes type 1, 2, and 3 consumable because they're using up the time of the therapist or of the helper, and therefore there's a limit to how many people we can help with those. But type 4, because they are fully automated, apps or websites, can be used by thousands of people at the same time anywhere in the world. And that gives them a great advantage in terms of accessibility. So let's look at what a type 1 kind of intervention might look like here. They would be used to train more providers, right? And we don't have enough psychologists, psychiatrists, social workers, or nurses, for example. So we could train lay health workers. There's work being done in India by Vikram Patel, and this study that came out in 2016 by Dixon Chibanda and colleagues, in which they trained lay health workers to do what they called the friendship bench intervention, in this case using problem-solving therapy to treat depression. And they found that these lay health workers were very effective. Now, one of the things that I find really encouraging is that we need to make sure that these interventions work beyond the place where they were developed, right? Darius Tandon at Northwestern University and his team are doing this very large-scale cluster randomized trial in 38 home visiting programs, comparing the administration of the Mothers and Babies course by mental health professionals, by lay health workers, and not using the course at all in these home visiting services. I'm very eager to see what will happen. The course has been translated to Greek by Krisa Georgiadis, and it's available for download on our website as well in Greek, if you're interested. And it's being used in Tanzania and Kenya. Mimi Lay has been doing work there.
Ninapokuwa na msongo wa mawazo, nitakaa sehemu yenye utulivu ambayo sitapata kelele yoyote ile. Nitashika tumbo na kufumba macho, huku nikihema taratibu na kuanza kufikiria sehemu nzuri ambayo waga natembea. Nikifika kule nafurahia na kuniondolea mawazo ambayo ninayo rohoni kwangu.
Research conducted in Kenya and Tanzania has shown that many mothers are at risk of stress and depression during pregnancy and after the birth of their baby. These new mothers often suffer silently for the fear of the shame that comes with it or the judgment that comes with it. And for women in the low-income countries where the project is implemented, access to mental health care services is also often limited. So the Mothers and Babies course is a community-based mental health intervention that helps those mothers and pregnant women and caregivers of children below 2 years to understand depression or stress, what causes it, how to regulate their mood to manage the stress, and improve the relationships that they have with their children.
Zamani.
So we need to make sure that these interventions work in different cultures, of course, before we begin making them available, through digital channels and so on. So type 2 interventions would be the face-to-face interventions with technology adjuncts. Imagine, again, going back to the friendship bench, if the lay health workers would be able to have, instead of a notebook there, a laptop or an iPad or another tablet, where they could show their clients a description, for example, of the cognitive behavioral circle that I showed you a little earlier, being described in their own language by somebody who can do it very, very clearly. This is a way in which we could enhance face-to-face interventions. Again, these would be type 2 interventions. Type 3 interventions would be guided self-help interventions, right? And here's an example published in 2016 in JAMA of a web-based guided self-help intervention for prevention of major depression in adults with subthreshold depression. This was done in Germany. And the study found that working with people at high risk because they had subthreshold symptoms, within a year, 41% of the people in the control condition developed a major depressive episode, compared to 27% in the intervention condition, which is a 34% reduction in incidence. And again, this was a type 3 intervention, meaning that they had helpers, guides, if you will, that helped the people to adhere to the online intervention. Type 4 intervention, fully automated ones, are being used, for example, by Aline Barrera, who is a member of I4Health, that has launched a fully automated mothers and babies online course in English, and soon it's soon going to be available in Spanish as well. Again, fully automated, so it's non-consumable. Now, the reason that I'm so excited about doing this through digital tools is that back in 1997, when I first began this work, there were 70 million internet users, which is 1.7% of the world's population. As of June of this year, there are 4.8 billion internet users, which is 62% of the world's population. The reach now is amazingly higher than it was back when I began this work. We need to take advantage of this. So we have indeed come a long way. In 1984, the state of the science said that the onset of a clinical depression cannot be prevented. In 2012, I was very proud to be able to publish an article titled Major Depression Can Be Prevented with my colleagues Bill Beardsley and Jan Lakin, published in the American Psychologist. In 1999, I gave a talk titled On the Road to a World Without Depression in Chile at the World Congress of the World Federation for Mental Health. At the time, this idea of reaching a world without clinical depression seemed more like a mirage, a hope. But now in 2020, we have the knowledge to reduce the incidence, the proportion of new cases by half. So we're halfway there in terms of knowledge, but of course not in terms of implementation. We need to focus on that, on how to make this happen. So the other thing we need to do is also to look at the other 50%, right? Is it time to tackle child's environment and poverty, for example, right? The environment has a well-known impact on human development. Epigenetics research has shown its major impact on gene expression, for example. Poverty has long been known to be a risk factor for many mental, emotional, and behavioral disorders. But of course, mental health professionals often feel that trying to reduce poverty is beyond our area of expertise, that we cannot do randomized controlled trials to prevent poverty. But we've talked about this. We've published articles on this. Tony Biglan and colleagues wrote a paper on the critical role of nurturing environments for promoting human well-being. And Bill Beardsley and colleagues wrote a paper in the American Psychologist on the effects of poverty on the mental, emotional, and behavioral health of children. Should we begin actually focusing on these things, right? And Biglan actually has a book out on the nurture effect, which I strongly recommend, that focuses on the effect of the environment on human behavior. And I was very excited to see that last year's Nobel Prize for Economics went to a group of researchers, of economists, who are using randomized controlled trials to see if we can reduce poverty. This article, published in Science in May 2015, reported on 6 randomized trials in Ethiopia, Ghana, Honduras, India, Pakistan, and Peru, in which they looked at the poorest villages in the country, and within those villages, the poorest households. They did a randomized controlled trial, looked at very many variables, of course, but they included mental health. And they found modest but measurable changes in mental health, quality of life, and stress levels. And in their report, they say that much more detailed psychological measurement would be necessary to fully understand this result and its underlying mechanisms. That sounds to me like an invitation to mental health professionals to join our economist colleagues to really see whether we can reduce poverty, and if doing so reduces the incidence and prevalence of mental disorders such as perinatal depression. So in terms of the next 40 years, what do I envision? In the next decade, we should ensure that prenatal care routinely includes interventions to prevent perinatal depression. We need to create digital apothecaries to develop, evaluate, and disseminate online preventive interventions or apps in as many languages as possible. We need to increase research on community and social variables that affect the incidence and prevalence of depression. In 2030 to 2040, we need to make evidence-based, individually focused interventions universally available to anyone in the world at no charge. This is now within our ability to do so. We need to do it. And we need to implement evidence-based community and societal interventions in as many countries as possible. 2040 to 2050, we need to begin examining the health and mental health statistics for our first cohort of adults who receive preventive interventions in the years 2020 to 2030. Right? Is the incidence and prevalence of depression in fact reduced if we can provide perinatal preventive interventions to everybody? Could we actually reduce the incidence of mental disorders in that cohort of babies born to those mothers? And we need to make community and societal interventions universally available, so both individual interventions and community and societal interventions. And then in 2050 to 2060, we would continue our efforts to reduce incidence of clinical depression to the minimum possible and enjoy a world without preventable depression. Now, sometimes people ask me, why am I so interested in doing things at the world level? And that's because I was born in Peru and grew up in a town called Chosica, small town 40 kilometers east of Lima. The western coast of Peru is a desert, and Chosica is a valley town fed by a river, the Rimac, which is the only source of life there. As you can see, everything else around Chosica is barren. And this image symbolizes for me what we could be doing with the internet. Right? The internet would serve as a river of information, ideally of evidence-based information, making available interventions through apps or websites that could help people deal with mental, emotional, and behavioral problems, including preventing perinatal depression. There are thousands of towns like Chosica all over the world, and I would like to be able to provide them with the latest information we know to prevent and treat mental disorders. So what I'm advocating for is that we should blanket the world with preventive and treatment interventions to protect as many mothers and babies as possible from perinatal depression. Thank you.